the average general practitioner might only see a single soft tissue sarcoma in their entire career. Just one.
Which is a pretty terrifying statistic when you think about it. It basically makes this specific type of cancer the ultimate diagnostic blind spot. I mean, they are incredibly rare, incredibly diverse, and notoriously difficult to catch before they become a massive problem.
Yeah, and catching them early is the whole ballgame. So today we are taking a deep dive into the updated 2024 UK guidelines for the management of soft tissue sarcomas. But first, for those of you tuning in to prepare for board exams like the FRCS in plastic surgery, this is a free episode of our journal club.
Right, and if your exams are coming up, you should absolutely head over to medsynclimited.com. You can get the FRCS plastic surgery ANKI deck there.
Exactly. It has over 7,000 questions arranged by topic to turn your revision into active recall. It is based completely on the plastic surgery curriculum, so it is really the go-to companion exam question guide. And definitely check out the full subscription-only library of clinical cases and journal club deep dives as well.
For sure. So, getting back to the guidelines, our goal today is to extract the most critical, life-saving nuggets from these clinical pathways.
Right, we're talking about how to spot a tumor that mimics everyday lumps, how to biopsy it without accidentally spreading the disease, and, the really intense balancing act surgeons face when trying to cure it. So let's unpack this. To start, what exactly are we dealing with here, and why does a doctor only see one in a lifetime?
Yeah, so we are looking at a malignancy that accounts for only about 1.4% of all cancer diagnoses in the UK. Soft tissue sarcomas, or STS, they arise in what we call mesenchymal tissues.
And for the listeners, in plain English, that is essentially the physical scaffolding of your body, right? Your connective tissues, your muscles, fat, blood vessels, and deep nerve sheaths.
Exactly, which means they could pop up literally anywhere. That is a huge part of the danger.
Right.
And to make matters worse, it's not just a single disease. The guidelines actually point out that there are over 80 distinct entities within this group.
Wow, over 80.
Yeah, because mesenchymal tissue is so foundational, so when those cells mutate and go rogue, they create a wildly heterogeneous group of tumors.
So if they are this rare and this varied, what actually triggers a connective tissue cell to turn malignant in the first place?
Well, for the vast majority of patients, we simply don't know the etiology. It just seems to be bad biological luck, honestly. But there are some fascinating genetic and environmental links that give us clues.
Like what?
On the genetic side, we see strong associations with inherited conditions where a patient's tumor suppressor genes are compromised, like mutations in the NF1 gene.
Oh, right, the one that causes neurofibromatosis.
Exactly. That can lead to nerve sheath tumors. We also see links to the RB gene, which is the same one responsible for familial retinoblastoma. When those genetic safeguards fail, the connective tissue cells just replicate unchecked.
Okay, so the body's natural brakes against cancer are basically missing. But what about outside factors? If it isn't always genetic, what environmental triggers are the guidelines warning clinicians about?
The most prominent one is actually previous medical treatment, specifically therapeutic radiation. So years or even decades after a patient gets radiation therapy for something like breast cancer, the DNA damage to the surrounding healthy tissue can actually spark a sarcoma.
Man, that feels like a cruel irony. The treatment that cures one cancer basically lays the groundwork for another one years later.
Yeah, it is a known calculated risk of radiation oncology. And another really striking environmental trigger is chronic lymphedema, which is when lymphatic fluid backs up and causes severe long-term swelling.
And that can be congenital or sometimes happen after a surgery.
Right. And over time, that chronic swelling and the localized failure of the immune system in that limb can lead to cutaneous angiosarcoma. It's a very aggressive tumor of the blood vessels, and we call this specific presentation Stewart-Treves syndrome.
Okay, so to understand why this disease is so lethal, we really have to look at how it hides in plain sight. What is the classic presentation? Like, what is the patient actually walking into the clinic with?
Usually, it is just a painless, enlarging lump. That is the classic presentation.
Yeah.
And because it doesn't hurt, patients just ignore it. They think they bumped their leg or maybe gained a little weight.
Right, especially since it often grows deep within the thigh muscles or hidden away in the abdominal cavity.
Exactly. By the time it actually gets properly diagnosed, the median size of a sarcoma is over 9 centimeters.
9 centimeters. I mean, that is the size of a grapefruit. Finding a sarcoma at an early stage sounds like finding a needle in a stack of needles.
It really is.
Because the vast majority of lumps people find on their bodies are just benign lipomas, right? Harmless collections of fat. So if a GP only sees one sarcoma in a career, how on earth are they supposed to catch it early?
Without sending every single patient with a benign fat lump into a total panic, you mean?
Exactly.
Well, if we connect this to the bigger picture, the entire first phase of the clinical guidelines is built around that exact dilemma. You need a system that acts as an effective, cost-efficient triage tool.
To separate the benign from the potentially deadly without overwhelming the hospital systems.
Right, so the rule they establish is this. Any adult with an unexplained lump that is increasing in size must be referred for a direct access ultrasound scan within 2 weeks.
Why ultrasound specifically, though? Why not jump straight to an MRI if we're worried about cancer?
Because ultrasound is fast, it's accessible, and it's brilliant at differentiating the density of tissues. An ultrasound wave bounces very differently off a fluid-filled cyst compared to a dense, vascularized sarcoma.
Or a uniform benign fatty lipoma, for that matter.
Exactly. It is the ultimate gatekeeper. If the ultrasound flags suspicious features, or even if it is just inconclusive but the lump keeps growing, that patient is immediately shifted onto a suspected cancer pathway.
And referred to a specialist regional multidisciplinary team, or MDT. So once that ultrasound flags something suspicious, the pathway shifts dramatically. The next step isn't to just cut it out, it's to figure out exactly what it is.
Yeah.
So walk us through this, because the guidelines have a very strict core rule about biopsies.
The absolute gold standard for diagnosis before any definitive surgery takes place is a percutaneous core needle biopsy. The specialist team uses image guidance, usually ultrasound or CT, to drive a hollow needle directly into the mass.
Yeah, and they snap out multiple tiny cylinders of tissue, right?
Right.
Okay, I have to push back here. Let's say a non-specialist sees a superficial lump, assumes it is just a stubborn cyst, and does what the guidelines call an unplanned excision. They just cut it out right there in a minor surgery room. Why is that considered such a disaster?
It's a huge issue.
Doesn't doing a needle biopsy risk spreading the cancer cells along the needle tract as you pull it out anyway? Like, why not just cut the whole thing out to be safe?
That is a very common fear,
Yeah.
but it misses the mechanical reality of how these tumors grow.
Yeah.
Let's tackle the unplanned excision first. Think of a sarcoma not as a smooth marble, but as a ball of mold growing inside a loaf of bread.
Okay, gross, but I see where you're going.
Right, so if you just scoop out the visible blue spot, the main lump, you are leaving behind microscopic spores all over the remaining bread.
Because you didn't take a wide enough margin of normal tissue around it.
Correct. A non-specialist doing a quick excision will almost always cut too close to the tumor. They leave microscopic cancer cells behind, which basically contaminate the entire surgical bed.
And then a specialist surgeon has to come in later and perform a massive, highly morbid revision surgery to fix it, right?
Exactly. Removing huge amounts of previously disturbed, healthy muscle and tissue just to guarantee they've cleared the invisible margins.
So you absolutely have to know exactly what kind of mold you were dealing with before you make that first cut. But what about the needle tract seeding?
Well, the data shows the risk of needle crack seeding is incredibly low. The cells don't easily survive in that narrow tract.
Oh, really?
Yeah, and furthermore, the biopsy path is tattooed or carefully recorded. That way, the surgeon can just excise that tiny tract along with the main tumor during the final surgery.
Ah, I see. So the benefit of knowing the exact grade and subtype of the 70-plus variations of sarcoma beforehand far outweighs that microscopic risk.
Without a doubt. And while they are testing that biopsy, they also have to stage the patient to see if the cancer has spread.
Right. So where does soft tissue sarcoma typically go? Because with things like breast cancer or melanoma, checking the nearby lymph nodes is usually the first order of business.
This is where understanding the biology is crucial. Unlike breast cancer, which tends to travel through the lymphatic fluid to nearby nodes, sarcomas are essentially tumors of the connective and vascular tissue.
So they love the blood vessels.
Exactly. They shed cells directly into the bloodstream, which is what we call hematogenous spread.
And all of your blood eventually filters through the lungs to get oxygen.
Right. The lungs basically act as a giant microscopic sieve. Those circulating tumor cells get trapped in the tiny pulmonary capillaries.
Which is why soft tissue sarcomas predominantly metastasize to the lungs.
Spot on. And why the guidelines mandate a CT scan of the chest for staging. Lymph node spread is actually very rare, only occurring in a few specific subtypes, like synovial or clear cell sarcoma.
For the vast majority, the lungs are the first trapdoor. Okay, so armed with a precise core biopsy and a clear chest CT, the MDT has to plan the cure. And this brings us to the most delicate part of the guidelines.
Yeah, taking out the tumor while saving the patient's physical function.
Because surgery is the baseline, right?
Yes. For localized disease, the standard is a macroscopically complete en bloc excision. En bloc meaning removing the tumor in one single uninterrupted piece.
Entirely encased in a rind of healthy, normal tissue to ensure those microscopic mold spores are gone.
Exactly.
But if these tumors are routinely the size of grapefruits and they are growing deep inside someone's thigh or arm, getting a wide rim of healthy tissue could mean chopping through major nerves, arteries, or the bone itself.
Which historically meant amputation. But amputations are now considered a last resort. The modern goal is limb preservation.
So how do they achieve that?
The guidelines allow for something called a planned close margin,
Meaning you intentionally leave the cancer cells right up against the edge?
meaning the surgeon intentionally shaves the tumor directly off a critical structure, like the sciatic nerve or a major blood vessel.
Wow.
Yeah, they leave a microscopic positive margin because removing that nerve would cost the patient the use of their leg entirely.
Here's where it gets really interesting, though. If you intentionally leave a microscopic margin of cancer behind in the patient, how do you actually cure them? Don't those cells just grow back?
Well, they would if surgery were the only tool. But you supplement that planned close margin with intense radiotherapy.
So the radiation acts as a sterilizing field, basically killing off those remaining microscopic cells.
Exactly. But the guidelines detail a really intense debate about when to give that radiation. It's a massive balancing act between preoperative and postoperative radiotherapy.
So how do doctors and patients make that choice?
It is a profound trade-off based on how radiation fundamentally damages tissue. If you give radiation before surgery, so preoperative, you use a lower dose, around 50 gray.
Because it is easier to target since the tumor is still right there.
Right. But radiation damages the DNA of normal cells, destroying their ability to replicate and heal. So when the surgeon goes in a few weeks later to cut the tumor out, the surrounding skin and muscle are deeply compromised.
Meaning the wound essentially won't close, or it gets horribly infected because the tissue is effectively dead.
Exactly. You see a significant increase in acute postoperative wound complications. It can be devastating in the short term.
So why not just do the surgery first, let the patient completely heal with healthy tissue, and then hit the area with radiation?
Well, postoperative radiotherapy does avoid those immediate surgical complications. But because the tumor is gone and the tissues have shifted, the radiation oncologist has to use a much higher dose,
Like how high?
typically 60 to 66 gray, and they have to blast a much larger area to ensure they hit any lingering cells.
And what does that do to the limb long term?
It causes severe late toxicity. Over years, that high-dose radiation causes permanent tissue fibrosis. The muscles turn hard and woody, the joints stiffen permanently, and the limb can suffer chronic, lifelong swelling.
So the choice is often between high risks of immediate surgical failure or a guaranteed loss of flexibility and comfort a decade later. That's brutal. How do you choose?
The biology of the specific sarcoma subtype often dictates it. For highly radiosensitive tumors, like myxoid liposarcoma, pre-op radiation is a miracle worker.
It just melts the tumor down, shrinking it away from the nerves and making the surgery vastly easier.
Exactly. But for a rapidly growing, painful tumor that isn't shrinking, early surgery followed by post-op radiation might be the only viable path.
So the limb-sparing strategy makes sense as a baseline, but the guidelines get wildly specific when the tumor changes location or disguises itself microscopically. Let's look at some of these anatomical exceptions, starting with retroperitoneal sarcomas.
Right, so the retroperitoneum is the deep space in the back of your abdominal cavity, behind the digestive organs. Sarcomas here present an extreme surgical nightmare.
Because the abdomen is so cavernous, right? These tumors often grow to the size of watermelons before the patient even feels them.
Exactly. And because of the crowded anatomy, you can't just carve out a wide margin of normal muscle like you can in a thigh.
Wait, if a tumor that massive is wrapped around the bowel or the kidney, a standard general surgeon can't just go in there and wing it, right? That sounds incredibly dangerous.
It is, which is why the guidelines strictly mandate these be handled by high-volume specialist centers, specifically units doing more than 24 primary cases a year.
Oh, wow. Because to get that clean margin around a retroperitoneal sarcoma, the surgeon often has to perform multivisceral resections.
Yes, meaning they take out multiple organs, they will remove the tumor en bloc, along with a perfectly healthy kidney, part of the colon, or sections of the pancreas and spleen.
They sacrifice completely healthy, vital organs just to ensure they have physically cleared the invisible microscopic borders of the tumor.
Yeah. It's intense.
That is staggering. What about gynecologic sarcomas?
The most dangerous trap here involves uterine leiomyosarcoma. Often, a patient presents with what looks exactly like a benign uterine fibroid. It's incredibly difficult to tell them apart preoperatively.
And fibroids are incredibly common, so how does a surgeon remove it safely?
Well, standard protocol for a presumed fibroid often involves a minimally invasive laparoscopic surgery. But to get a large fibroid out through a tiny keyhole incision, surgeons sometimes use a device called a morcellator.
Which essentially acts like a localized blender, right? Cutting the tissue into strips to pull it out.
Exactly.
Oh no, if that fibroid is actually a hidden sarcoma.
It is a complete catastrophe. If you spin a blade inside a hidden sarcoma, you disseminate aggressive cancer cells throughout the entire abdominal cavity.
Turning a localized, curable tumor into an incurable systemic disease.
Yes, which is why the guidelines place a massive red flag warning against morcellation if there is any suspicion whatsoever of a uterine sarcoma.
Okay, let's shift to breast sarcomas. If
Yeah.
someone develops a primary sarcoma in the breast, do you treat it like normal breast cancer?
No, and this goes back to our earlier point about how sarcomas spread. Epithelial breast cancer travels through the lymphatic fluid, so sentinel lymph node biopsies are standard practice.
But primary breast sarcomas travel through the blood.
Exactly. They don't use the lymph nodes.
Right.
Therefore, the guidelines clarify there is no need for sentinel lymph node staging. The entire focus is purely on achieving clear, wide margins through excision or mastectomy.
That makes sense. And that brings us to one final, fascinating exception, the borderline tricksters. The guidelines talk about atypical lipomatous tumors, or ALTs,
Right.
but they also say an MRI often cannot definitively tell the difference between a massive benign fat lump and an ALT. If the imaging can't tell, how do we ever know for sure what we are dealing with?
What's fascinating here is that the defining diagnostic test isn't visual at all. You can't rely on the MRI, and sometimes even looking at the cells under a microscope isn't enough.
So what do you do?
The definitive proof requires a genetic analysis on that initial core needle biopsy.
What are they looking for exactly?
The pathologist uses a technique to look for the amplification of a specific gene called the MDM2 cell cycle oncogene.
And what does that gene do when it's amplified?
So MDM2 is basically a regulator that tells cells when to divide. When it is amplified, meaning there are way too many copies of it, it essentially jams the accelerator to the floor.
So the fat cells start replicating endlessly, turning what looks like a benign lipoma into an atypical lipomatous tumor.
Exactly. And if the MDM2 gene is amplified, you treat it like a cancer.
Because it completely alters the surgical approach, yes.
Yes. ALTs don't usually metastasize to the lungs, but they are notorious for growing back locally and causing massive damage to nearby structures.
So knowing that genetic signature means the surgeon knows they have to perform a complete en-bloc resection rather than just scooping out a harmless fat lump.
Precisely. But despite all these surgical heroics, the multivisceral organ removals, the planned close margins, the radiation, high-grade sarcomas still have a high rate of metastasis.
Usually returning in the lungs, as we discussed.
Yes.
So how do the guidelines direct care when the disease becomes advanced and systemic?
When a sarcoma metastasizes widely into the bloodstream and lungs, the intent of treatment unfortunately shifts from curative to palliative. Historically, the prognosis has been very grim.
We're talking about a median survival for metastatic disease hovering around 12 to 18 months, right?
Yeah, though modern therapies are starting to stretch that. But if surgery is off the table, systemic anti-cancer therapy, or chemotherapy, is the go-to.
What's the standard first-line treatment?
It remains a drug called doxorubicin. Sometimes it is combined with ifosfamide if you need a rapid, aggressive reduction in tumor volume to relieve severe pain.
But that combination brings heavy toxicity without necessarily extending the patient's overall survival, doesn't it?
It does. It's a tough balance.
So what does this all mean for the future? Are we stuck relying on decades-old chemotherapy drugs for a disease with over 80 different subtypes?
We aren't. And this is where the guidelines show the horizon of sarcoma care. We are finally moving away from the blunt instrument of one-size-fits-all chemotherapy and entering an era of precision genomics.
Meaning you treat the specific mutation, not just the body part.
Exactly. For instance, if that original core biopsy undergoes genomic sequencing and reveals an NTRK gene fusion, which is a specific structural error in the DNA, we can now use targeted NTRK inhibitors.
And these oral drugs block the exact signaling pathway the tumor uses to grow, leading to incredible response rates in tumors that wouldn't respond to doxorubicin.
Exactly.
What about immunotherapy? I mean, it has completely revolutionized how we treat things like advanced melanoma.
Sarcomas have traditionally been very resistant to immunotherapy, which has been really frustrating. But we are seeing vital breakthroughs.
Like what?
Recently, an immune checkpoint inhibitor called adalimumab was approved for a rare subtype called alveolar soft part sarcoma, or ASPS.
How does that actually work?
ASPS tumors are essentially invisible to the body's immune system. Adalimumab strips away that invisibility cloak, allowing the patient's own T cells to recognize and attack the sarcoma.
And because ASPS is completely insensitive to traditional chemotherapy, finding a targeted immunotherapy that actually works is a massive paradigm
It
shift.
really is.
That brings us to a really fascinating paradox to chew on as we wrap up today's deep dive. We have spent this entire time discussing the massive macroscopic destructive nature of these tumors.
Yeah, we are talking about 9-centimeter masses, limbs pushed to the brink, and surgeons removing entire healthy organs just to guarantee a clean margin.
Yet the entire future of curing this disease might not rely on the surgeon's scalpel at all. Instead, it relies on the tiny microscopic genetic sequences extracted from that very first needle biopsy.
Right. The smaller our focus gets, down to those MDM2 amplifications and NTRK fusions, the better our chances of survival become. It is the ultimate shift in medicine, moving from macroscopic destruction to microscopic precision.
To everyone listening, we want to hear from you. Leave a comment or a question below. Which specific sarcoma subtype or surgical challenge did you find most surprising today? Keep questioning the world of medicine around you. And remember, when you are looking at a seemingly ordinary lump, you might just be looking at that one needle in a stack of needles.
Thanks for listening.